Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the PQRS What You Need to Know in 2015 webinar. Our lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. And now, without further ado, it is my pleasure to turn the floor over to your host, Ms. Lawyer Sawyer.
Thank you, and welcome to today's webinar presented by the Lake Superior Quality Innovation Network. The LSQIN is comprised of three organizations: MPRO in Michigan, Metastar in Wisconsin, and Stratis Health in Minnesota. Together, we support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. I would like to introduce you to today's speakers. First, we have Hanson, Program Manager at Stratis Health. Candy has more than 20 years of experience working in long-term post-acute care settings and public health. She is a graduate of the Leadership in Health Information Technology for Health Progressions program from the University of Minnesota and is also a graduate of the Practice Facilitation Certification program from the University of Buffalo. Also joining us today is Gwen at Stratis Health. Gwen has more than 35 years of hands-on experience in healthcare. Her background includes developing process strategies, implementing quality innovations, and evidence-based guidelines for healthcare providers. She has worked with clients in choosing, integrating, and reporting clinical quality measures to federal and state entities, and provides physician quality reporting system technical assistance to Minnesota clients. Lastly, we have Jen Schnabel, Project Manager and Account Manager at Minnesota Community Measurement. She is responsible for initializing and managing large-scale projects that align with the mission of Minnesota Community Measurement. This includes relationship management, contract and grant management, facilitation of project meetings to achieve consensus and efficient decision-making by all stakeholders. At this time, I would like to turn it over to Candy.
Thank you, Laura. Gwen, next slide. So, as Laura mentioned, we just want to reiterate that we are the Lake Superior Quality Innovation Network, and we are the three quality improvement organizations of MPRO in Michigan, Stratis Health in Minnesota, and Metastar in Wisconsin. Next slide. So this is just our contact information for the program leads for the PQRS program in each of the respective states. And we'll list the contact information again at the end of the presentation. Next slide. So our objectives for today are to learn the final reporting requirements for PQRS in 2015, learn the methods available for reporting in 2015, find out if your organization should be reporting PQRS data, hear specifics about clinical qualified data registry reporting, and then learn about the education and technical assistance that is available to your organization. Next slide. Gwen?
Well, thank you, Candy. Welcome to the overview of the PQRS reporting program for 2015. We are all aware that PQRS is a complex program and that the reporting requirements often change from year to year. We do plan to provide an opportunity at the end of this webinar to respond to your questions, so let's get started. In 2015, there are three CMS Incentive Programs available. The first is an annual reporting of quality measures to CMS, and that is either done through the Inpatient Quality Reporting Program for hospitals or the Physician Quality Reporting System, or PQRS, for outpatient setting. The second incentive program is the Value-Based Modifier Payment Program. This is a complex program, but in a nutshell, the value modifier is a per-claim adjustment under the Medicare Physician Fee Schedule that is applied to the group at the TIN level, the tax identification number. CMS has created an algorithm that includes the group outcomes of the PQRS quality measures and the cost of providing that care through evaluating the group's claims. The 10-level group will fall in 1 point on a 9-point matrix. For example, high quality and low cost, or high quality and high cost, or low quality and high cost. There are 9 different possibilities on the 9-point matrix. So once a group is fully participating in the program, the point on the matrix will determine whether CMS will impose one of 3 options. It could be up to a 2% increase in the reimbursement level for the TIN's Medicare physician fee schedule for the calendar year. It could be up to a minus 2% decrease in that reimbursement, or it could be a neutral or no change in reimbursement. The program is implemented using a phased-in approach. So groups of 100 or more EPs began in 2013, and they would be affected by the quality tiering and payment adjustment in 2015. Groups of 10 to 99 EPs began in 2014, and they will be affected by the quality tiering and payment adjustments in 2016. And the smallest group of EPs, 1 to 9, will begin in 2015, and they will be affected by the quality tiering and payment adjustment in 2017. So in summary, there is a 2-year look-back period. The first year of participation, there is no penalty, but the provider group could see up to a 2% increase in their reimbursement or no change for the calendar year. Groups participating EPs are eligible for penalties beginning in year 2. And just to note that the 2016 value modifier does not apply to groups of physicians who participate in other CMS programs. For example, the Medicare Shared Savings Program, the Pioneer ACO program, and the Comprehensive Primary Care Initiative. The third incentive program is the EHR incentive program, which most of us are familiar with. There is the Medicare and the Medicaid incentive program. We're talking primarily today about the Medicare program. In general, EPs are subject to a penalty if they have not started participation by 2014. And just to note, if the EPs choose the Medicaid program, and they also bill Medicare for any reason, then they are eligible for the Medicare payment adjustments as well. So in summary, the payment adjustments or the penalties for all 3 of these incentive programs will be added together to determine reimbursement levels for a calendar year. So participation in all 3 programs is highly recommended. So why PQRS? CMS will tell you that it gives participating eligible professionals the opportunity to assess the quality of care they provide to their patients. It helps to ensure that patients get the right care at the right time. It helps providers to quantify how often they're meeting a particular quality measure, and EPs can compare their results with their peers by using the CMS feedback report. The 4th bullet point is most important. We're seeing a reimbursement model change in Medicare from fee-for-service to pay-for-reporting, pay-for-performance, and pay-for-value. So this is a very exciting and historical change in the way health care is provided and paid for. This is a screenshot of the links that are available to you on this CMS PQRS website. They're all important links, but I want to point out a few to you that are helpful in particular. The first one is Spotlight, and that is where the new 2015 information is originally placed. The second link, How to Get Started, you will find documents in that link to describe the eligibility and the ability to report PQRS. The measures code, which is highlighted here, will provide you with the 2015 implementation guide, along with a list of the 2015 PQRS quality measures based on the reporting method chosen. And then there are additional links below that for each individual reporting option. And in those links, you will also find a quick reference guide to those reporting options as well. There are some general guidelines on 2015 that apply across the board. Requirements and measures often change from year to year, so you need to stay within the current reporting year. PQRS reporting is a 12-month calendar year. 2014 was the last year to earn PQRS reporting incentive. So beginning in 2015, participation is to avoid the 2017 penalty of 2%. Another important change is that EPs who bill through their critical access hospital using Method 2 billing may participate in PQRS using all reporting methods in 2015. If you are reporting PQRS measures in 2015, you need to use the 2015 PQRS quality measures that are on the measures codes link, except for EPs and group practices who choose to report clinical quality measures electronically. They must use the updated July 2014 version of the electronic clinical quality measures to report in the 2015 program year. And there are two additional groups of eligible professionals in 2015. One is the advanced practice registered nurses, and the other is the anesthesiologist assistant. This slide shows eligibility for all three incentive programs. On the left is a list of all of the providers, the practitioners, and the therapists. And you can see in the yellow shade here that all of those are eligible for the incentive for PQRS reporting. The next column shows that they are all eligible for the payment adjustment as well. The value modifier program is the next column, and it's the same eligibility. However, if you notice that only Medicare physicians are subject to the penalties for the value modifier program. And then you have the EHR incentive program. The first column identifies the eligible professionals for the Medicare incentive program. The second column shows the eligibility for the Medicaid program, and you can see that that is slightly different. And the third column shows which Medicare physicians are eligible for the EHR incentive program Medicare payment adjustments. So there are three ways to report PQRS in 2015. One is to report as an individual EP. These participants are analyzed at the rendering provider level or the individual NPI number. There is no registration required for that. The second way is to report as a group through the group practice reporting option. These participants are analyzed at the tax identification number or the TIN of an organization, so all the individual NPI numbers are attached to one TIN. There are three group sizes, basically, 2 to 24 EPs, 25 to 99, and 100 and over EPs, and your reporting options as a group are based on the group size. Registration is required to report as a group with the physician value physician quality reporting system. It must be done between April 1st of 2015 and June 30th of 2015 at that secure portal that is listed there. And there are specific step-by-step processes available to you in Appendix F in the 2015 implementation guide on how to register. The third way is to report your participation in other programs. So if your EPs are participating in the Medicare Shared Savings Program, the Pioneer Accountable Care Organization model, or the Comprehensive Primary Care Initiative, then you must contact those organizations to learn the requirements for PQRS reporting. In the National Quality Strategy domains, we're all becoming quite familiar with these. These are domains that were created by the Agency for Healthcare Research and Quality, or the ARAC organization. They consist of 6 healthcare priorities that support 3 common goals. The first goal is to provide better care. The second goal is to provide for healthy people and communities. And the third goal is to provide affordable care. These 6 domains are tied to the CMS quality measures, and the 6 domains are the same domains used for the PQRS program and the Meaningful Use EHR Incentive Program. There are 5 ways to report PQRS as an individual. The first is claims-based reporting, and that includes only Medicare Part B claims. I would refer you to the 2015 implementation guide because there is additional information about claims reporting for 2015 this year. The second option is the qualified registry. A qualified registry vendor is chosen from a list of CMS approved vendors, typically that is published about mid-year. You would be reporting on 9 quality measures from 3 domains, or you could report 1 to 8 measures for 50% of each EP's Medicare Part B fee-for-service patients. And new for 2015 are the cross-cutting measures. For any EP or group practice who sees 1 Medicare patient in a face-to-face encounter must also report at least 1 cross-cutting measure. And we'll talk more about these in the next few minutes. So quality measures cover only Medicare Part B fee-for-service patients. And the other point I would like to make here is that you would have the option of reporting individual measures or measures groups. An easy example I like to give for individual measures is if you were reporting on, say, diabetics who had an A1C of less than 8. On the measures group, it's several components that make up the measure, and all of those components will need to be met to meet the measure. So, for example, A1C less than 8, along with LDL less than 100, blood pressure less than 140 over 90, and that the patient was tobacco-free. So that's the difference between measures and measures groups. The third reporting option is the direct electronic health record that is certified HRT or health certified electronic technology. This vendor is certified by the Office of the National Coordinator to provide the ability to report directly through the EHR. It is possible with this option to report quality measures once for both meaningful use and for PQRS. You need to remember that the PQRS reporting is always a 12-month period, regardless of your stage or year of meaningful use reporting. This option is not available to first-time meaningful use attesters. The EP would indicate on their CMS attestation that they intend to use this method at the time that they attest to meaningful use, and they would continue to report their core and menu measures at that time, and they would submit the PQRS at a later date. So this would mean that the organization would be required to prepare and submit the PQRS report to the PQRS portal, usually within 60 days of the beginning of the new calendar year. You would be reporting on 9 quality measures covering 3 domains, and if the EP also qualified for a meaningful use incentive, then this payment would be delayed until CMS could evaluate all of the data that has been submitted. The EHR data submission vendor that is certified EHR technology is another option for you where the EP or the group practice would hire an EHR vendor, and this would usually be their own vendor, to prepare the clinical quality measure report and to submit to CMS in the format that CMS requires by the deadline. You would be reporting 9 quality measures covering 3 domains. The EP would also indicate on the CMS attestation page their intent to report their quality measures in this way. And if the EP qualifies for a meaningful use incentive payment, then that incentive payment would also be delayed until CMS could validate all the data submitted. The fifth option for you would be the Qualified Clinical Data Registry. CMS will provide an updated list of the Qualified Clinical Data Registries by mid-2015. We're fortunate today to have Minnesota Community Measurement here to help explain this particular reporting option. There are 2 main differences, however, that I would like to bring out to your attention. The Qualified Clinical Data Registry covers measures across multiple payers and not just Medicare Part D patients. And the other main difference from the Qualified Registry is that in 2015, The qualified clinical data registries are able to add up to 30 non-PQRS measures for reporting. So both of these differences can provide more reporting flexibility to EPs. And when CMS does publish that list of qualified clinical data registries, you will find the Collaborative of Wisconsin listed, and Minnesota Community Measurement partners with the Collaborative of Wisconsin to provide this reporting option. Take a look now at the 2015 group practice reporting options. As you can see, we basically have three groups sizes, 2 to 24, EPs 25 to 99, and 100 plus EPs. The type of reporting is based on the size of the group, and all of the individual NPI numbers are attached to one TIN or tax identification number. You'll see that the first three reporting options in each group are the same. The qualified registry, which we talked about, the direct EHR product that is certified EHR technology, and also the EHR data submission vendor that is certified EHR technology. So the difference in the group reporting comes down to the web interface option and also the PQRS CAHPS survey reporting. If you look in the first column on the fourth bullet point, you'll see that you would be reporting 9 quality measures across 3 domains. If the groups 2 to 24 chose to report the PQRS CAHPS survey, then they would only need to report 6 additional quality measures covering at least 2 additional national strategy domains. Now, one of the methods listed 1 through 3. They are not required to report the CAHPS survey. That is optional. In the group of 25 to 99, if you notice the fourth bullet point, they're mentioning the web interface. The web interface is a web-based reporting tool that is partially pre-populated with an assigned sample of Medicare Part D physician fee schedule beneficiaries. And in 2015, it would be the first 248 Medicare beneficiaries that have been identified for this group or any particular group based on claims history. If the groups of EPs of 25 to 99 would choose to report the PQRS CAHPS survey, then they must report on all of the web interface measures. And there are a total of 21 measures in the web interface. As you can see, that the last bullet point in that column, that if this size group decides to report the PQRS CAHPS survey, then they're able to reduce the number of actual clinical quality measures they report on from 9 to 6, covering at least 2 additional domains instead of 3. And those options would come from the first 3 options listed in that column. And then the 100 plus EP group, if you look at the fourth bullet point, it identifies the web interface. A group of this size would need to report on all of the measures in the web interface, if that's the method they chose. But notice the fifth bullet point, that the CMS certified PQRS CAHPS survey is a requirement for PQRS satisfactory reporting for the 100 plus EP group. A word about the CAHPS survey. CAHPS stands for the Consumer Assessment of Healthcare Providers and Systems. It is a patient experience survey and not a patient satisfaction survey. CAHPS oversight is provided by the Agency for Healthcare Research and Quality, the ARAC group. And CMS has a family of CAHPS surveys. There are many, many surveys to cover many, many patient experiences. The PQRS CAHPS survey can be used for satisfactory PQRS reporting. And generally, like we mentioned before, if you're going to report on the PQRS CAHPS survey as a group, that generally it is equal to 3 individual measures and 1 to 2 national quality strategy domains as a substitution. Beginning in 2015 reporting year, CMS will not bear the cost of administering a CAHPS survey for any group for PQRS reporting, and that's different from last year. The PQRS CAHPS is required for groups of 100 plus EPs, like we mentioned before, but it is optional for groups of 2 to 99, and we've just combined the first two groups to come up with 2 to 99 EPs. And the third bullet point here just describes this scenario in a bit different way. Beginning in 2015, the PQRS CAHPS survey will have 3 options for group practices to satisfactorily report. 2 or more EPs reporting by the qualified registry can report the PQRS CAHPS survey, or 2 or more EPs in groups reporting by either EHR method with the PQRS CAHPS survey, or groups from 25 to 99 can report as a group practice reporting option using the web interface. The CAHPS survey is made up of 12 very specific modules that it measures. I'm not going to read these to you, but I would just point you to the resource at the bottom of the slide. There is a document called the 2015 CAHPS for PQRS Certified Survey Vendor Made Simple. It will be published on the educational resources soon, but right now you can find it in the special link for the CMS Certified Survey Vendor link on the PQRS website. A word about selecting measures for PQRS reporting. CMS is recommending 3 steps. The first step is that you would review the 2015 PQRS measures list, which can be found on the measures codes link. The second step is to consider some factors about your organization itself. What clinical conditions are usually treated there, the types of care that you typically provide, whether that be preventative or chronic or acute. Look at the settings where the care is usually delivered, the office, maybe the emergency room, or perhaps surgery even. Look at your quality improvement goals for 2015 as an organization, and then consider other quality reporting programs that you're currently using or maybe considering. Then the third step would be to go back to review the specification for each measure considered. And you would want to focus on selecting measures that apply to services provided to Medicare patients. Cross-cutting measures for 2015. This is a new requirement. We talked about it a little bit already. EPs will report individual measures using either a claims reporting option, which would only be for individual reporting, or the registry reporting, the qualified registry reporting, which would be either as an individual or as a group. They would be required to report 1 cross-cutting measure if they have at least 1 Medicare patient with a face-to-face visit. There are a total of 19 cross-cutting measures, and they're found on the Measures Codes link on the PQRS website. On that Measures Code link, you'll also find a description of the 2015 PQRS list of face-to-face encounters that are described there for the purposes of PQRS reporting. The Measure Applicability Validation Process, or MAV, EPs and groups of all sizes could be subject to the MAV process if they choose to report by either the individual claims method or by the qualified registry. The objective of the MAV is for CMS to validate if there were additional measures or domains that may have been applicable to report by the EP or the group. The MAV is actually a 2-step process. Step 1 is a process where they compare the clinical versus the domain relationship test, and the second step is a minimum threshold test. The process may benefit some EPs and group practices, but it also could validate that some EPs and group practices should or could be reporting more measures than they are, and in that case they could be eligible for the 2017 payment adjustment. If you go to the analysis and payment link on the PQRS website, you're going to find 2 documents there. The first would explain this NAV process for claims reporting, and the second document would describe the NAV process for the qualified registry-based reporting process. Just a word about Physician Compare website. This is a consumer website. It was launched in 2011 as part of the Affordable Care Act. You can access the site at this location mentioned here on the slide. Its purpose is to provide information for consumers to encourage healthcare decisions, informed healthcare decisions, and to create explicit incentives for physicians to maximize their performance. CMS has planned a phased-in approach of information on physicians, group practices, and quality measure outcomes, including reporting the PQRS CAHPS survey results from the Medicare Shared Savings Program and the Accountable Care Organization reporting. Physicians Compare uses feedback from the public and other stakeholders to make improvements to the website. This concludes this portion of our webinar today. This is a list of resources for you that you can access. And the next slide is also a list of phone numbers of where you can call for help, for additional help and discussion. Thank you. And I will turn this back over to Gwen, it looks like.
Thanks, Gwen. There we go. Gotta wait for WebEx to catch up with us. So thank you everyone for attending the webinar today. I'm just going to be reviewing the facts about Minnesota Community Measurement PQRS program for 2015. Our quick agenda for this portion of the webinar, we'll be looking at two things in the next 10 minutes here or so. One, I'm going to go through an overview of Minnesota Community Measurement PQRS program for the upcoming year, and two, we'll review the steps for any interested groups for follow-up. Minnesota Community Measurement, as Gwen has mentioned, has had a PQRS partnership with Wisconsin Collaborative for Healthcare Quality for the past 7 years. So together we're qualified to submit data for both the group and individual providers. I know that is a question that comes up for us, though, is that when you look at the CMS website, you'll see Wisconsin on there and not us. But we work closely with them to report for Minnesota and Wisconsin groups right now. So Minnesota Community Measurement has what we consider a 4-step approach to PQRS reporting. I'll dive into each step in greater detail in my following slides, but just an overview of this. First, your organization needs to select whether you're reporting as individuals or as a group. And as Gwen mentioned, you have to have that group reporting option selected with CMS significantly before we actually start any data submission. From there, we have step 1.5, where you select your measures. Second step is to submit validation documents. And third, your organization creates and submits the data files for calculation. And finally, we recognize that PQRS submission will not be successful without the active participation of any submitting organization. It's very common for us to have some back and forth during the process and to really tweak and do some problem solving to make sure that we have the best data in the final calculations. So some more details of step 1. As I mentioned, we report both group and individual reporting options. For individual reporting, Minnesota Community Measurement utilizes the methods of the direct EHR and then the data submission vendor options. And you can submit the link too for greater detail on the group reporting. The next step is to select your appropriate measures. As Gwen mentioned, you select the 9 measures that cover at least 3 quality domains, unless you're working with the CAHPS vendor. And really selecting measures that apply to your type of providers. One thing to note is that while Minnesota Community Measurement and Wisconsin Collaborative for Healthcare Quality do offer an extensive suite of PQRS measures, we don't offer every single PQRS measure that's available. So it's really important to review the list of available measures that we have before selecting your vendor to make sure that we're a good fit for your organization. This is just a quick overview. We haven't selected and finalized our measures for the 2015 program, but this gives you a good idea of what we have for 2014. The first slide here is our DSV measures, and then the second slide is an example of our registry measures. And there is a slight difference, too, in the measures offered for each of the programs, so it's also something to note while reviewing for vendors.
The final step here at MNPM is to go through some of your pre-data submission activities. Go through your queries, narratives, and data dictionary. All of these pre-submission activities are really designed to minimize issues to data files downstream. It helps us to catch any issues that you might have in how you're pulling your data, and just really helps to minimize issues. Our third step is preparing and submitting the data files. PQRS requires a variety of data submission files that are broken down in billing and clinical and encounter. We really try to make the process as easy as possible by having a comprehensive data submission guide that really walks you through each step and gives you the details for each file. From there, we have the, like I mentioned, the patient file, encounter, clinical data, and measure-specific files. Finally, Minnesota Community Measurement does extensive checks to ensure that your data is ready to be submitted. And as I previously mentioned, we do ask that you be an active participant. One thing, especially for groups who are new to PQRS, is it's kind of a shock in how much time it takes in those weeks following the initial data submission. But we really need that involvement to be able to ensure that your final data is an accurate representation of your organization. Here's a high-level timeline of our process for the next year. We do get much more granular the closer we get to the end of the year. Right now, we're really in this phase where it's just discussing eligibility and reporting requirements for your organization and how it meets with Minnesota Community Measurement capabilities. In October and December, we start doing provider and measure registration for your organization with us. And then between now and mid-January 2016, we can start some of the pre-validation coding. End of January, February of 2016 is really when we get into that crunch time of the actual data submission and submitting everything to CMS. And finally, with our next steps, if you are interested in Minnesota's services for the next year, or if you have any questions specific about our program, feel free to email us at opportunities@mncm.org. We will be sending updates throughout the fall for any of those organizations who are interested in receiving them. We'll also host a webinar specific to our services in the fall to review the process and requirements. So I will hand things back over then.
So, Jen, do you want to just take... Yep, there you go. Thanks a lot, Jen. So this is Candy Hanson again. And so we just wanted to take a minute and let you know about the quality improvement initiatives that the LSQIN will focus on over the next several years. As you can see, there are seven initiatives here that when you first look at them appear to be different, but we're really encouraging going across all tasks when we look at participating in these initiatives. As Gwen mentioned, it's a very exciting and also challenging time to be in the healthcare industry related to payment reform and quality reporting. And so, for example, if you chose to participate in an initiative around PQRS reporting, you could make your efforts more efficient in your organization, for example, by choosing measures that were related to cardiac care or diabetes care that would go across different initiatives. And so you basically get more bang for your buck when it comes to education and technical assistance. Next slide. So if you were interested in as an organization in participating with your LSQIN, we'll be working with you on quality improvement strategies, of course, and of course to improve those quality metrics. As Gwen mentioned, there's two parts to payment adjustments that will be available to people, and so our work would be to work with you to, in as much as possible, either stay payment neutral or perhaps even receive a positive payment adjustment as a result of your quality improvement work. You also have an opportunity to network with similar facilities and practices for support and best practices, and then collaborate with other initiatives, as I mentioned, sharing education and interventions as we go through this work together. Next slide. Most of the work that we will be providing out of the LSQIN will be related to education and technical assistance. So the IX account that's named in the first bullet point is related to group reporting for PQRS reporting, and then also some assistance with measure selection and improvement strategies, and help with PQRS submission education and these other areas that are listed here as well. Next slide. So in terms of education, we are you have access to all learning sessions. We are working on creating an all teach, all learn environment. And related to PQRS, the education is again related to quality improvement, the value-based modifier program, PQRS, the quality resource utilization report, and cross-initiative education. Next slide. So expectations, there are expectations for participating with your LSQIN. Certainly we want to work with you to create quality improvement goals. We would ask that you provide quarterly submissions of PQRS reports. We've had lots of questions about what do we do with that data. Is it, is it de-identified data? It's data that we take in as an LSQIN or as a quality improvement organization. And the reason that we're asking you to provide quarterly reports is so that we can help you do quality improvement, see your scores earlier on to be able to get the most out of your quality improvement efforts. And we don't share data with anyone else. It's just basically to receive individualized technical assistance to help you meet your goals. And then participate in learning events and participate in the individual technical assistance, and then just ongoing participation. Next slide. So if you're interested in participating with any of the states, any of our 3 states, here's our contact information. I'll also leave that or refer you to the contact information. We're going to open it up for questions now. But if we don't happen to get to your question, or if you're looking for some other follow-up following today's webinar, we encourage you to get a hold of each of the task leads, as well as if you're interested in participating in any of the other initiatives. So at this time, we are going to open it up for questions.
Thank you, ma'am. Ladies and gentlemen, the floor is now open for questions. If you do have a question, you may press the number 7 or the letter 2 on your telephone keypad. Questions will be taken in the order they are received, and if any point your question has been answered, you may remove yourself from the queue by pressing the number 7 or 2 again. If you're using a speakerphone, we ask that while posing your question, you use your handset to provide favorable sound quality. Okay. Please hold for a moment while we wait for the first question. I have no audio questions at this time, ma'am.
Okay, let's just give a minute here. We're also going through our chat questions to make sure that we've answered those questions as well.
I do have one audio question in the queue. One moment, please.
Sure.
The question comes from Adrian Moore. Go ahead, ma'am.
Hi, I was checking to see if FQHCs are not required to report your PQRS, and we had a provider that was working at a non-FQHC facility, would we be required to report for them?
Well, this is Gwen. Can you hear me?
Yes, I can.
Oh, okay, great. So think of it this way, that an individual EP's NPI number is attached to an organizational TIN, or tax identification number. So that EP could technically work in several different organizations and still report PQR successfully for that organization. So you bring up a good point, because if that EP is seeing patients and billing through the FQHC, they are not able to report PQRS. But if that same EP is seeing patients at another location where he or she is billing Medicare Part D, then those claims are going to show up, and that EP will be required to report PQRS.
But only for those services at the non-FQHC facility.
Right, because FQHCs don't bill Medicare Part D directly, and that's what PQRS is all about, Medicare Part D fee-for-service billing.
Great. Okay. Thank you very much.
You're welcome.
There are no more questions in the queue.
Okay. Is there anything else in chat that we need to answer?
This is Jerry, and I'm just looking through chat quick, and I did just want to reach out to the Minnesota providers. We will be checking on the SQUIRMS question. We answered that in chat too. It just that also refers to hospital reporting, so we want to make sure that we cover all aspects of that, and so we can send that answer out to everyone who's participating from Minnesota. We have one other question, I think, too. Someone asked if PQRS is separate from the Minnesota Community Measurement Reporting. I'm not sure we got that one answered, and yes, this is different from the measures that you report into Minnesota Community Measurement that are required, but, and I think Jen's on the line too, Minnesota Community Measurement does also do PQRS reporting as a registry, as she noted in her presentation. So I'm not quite sure what the question was referring to, if it was talking about PQRS reporting that Minnesota Community Measurement does, or if they meant the Minnesota Community Measurement reporting as a whole. Hopefully that answered the question.
I know a common question that we have is that people think that they can do our DDS submission and that should qualify for everything, but there is a difference in the files and some of the information that's pulled. But that being said, we are able to, through PQRS reporting, pull out some of our DDS measures so we can work it in reverse. But I know that's a common confusion for folks because it is just level, so.
The other part of that question was too, so is PQRS separate from meaningful use reporting? And I think we might have answered that too, that it is separate from PQRS and meaningful use are the same reporting.
And although CMS is working to align the measures, currently I believe there are only 64 measures that are aligned at this time. So it's going to be a little while before that occurs at the level that will be most beneficial.
And I just want to follow up on one other question in chat here. It says, how many GPRO web interface measures are there? I see 17 for 2015 in the documentation, but on our presentation we said there are 21. So I'm just kind of throwing that one out there. Gwen, if you're still on, I'm thinking...
Well, I want to check on that because I was pretty sure that I received that information from the 2015 implementation guide. So I'll do some research on that and get back to that question. If you can just give me your email address or some way to reach you, I'd be happy to clarify that point for you.
Actually, Gwen, we'll just send it out to everybody because everybody probably has the same question. So we'll just send it out to everybody when we send out the slides.
Okay.
And a reminder to everyone that presentation will be available on YouTube at the LSQIN website.
And I do have two questions in the queue now.
Okay, go ahead.
I think the first question comes from Kathy Hedrick. Go ahead, ma'am. Your line is open.
Hi. I am asking in regards to we report through claims for individual EPs, and we have read some information about having to report for 2014 some 248 consecutive data entries. And then when I look again, it appears to me that for individual claims that maybe we don't have to do that, that just is related to group. So I just would like clarification if we are reporting as individual EPs via claims. Are we exempt from doing the 248 consecutive? We can just report on 50% of our Medicare claims submitted?
Okay, this is Gwen, and if I'm understanding your question correctly, if you're reporting individually and you're recording in a claims-based option, that you would be reporting on the quality measures on each individual claim that you would be sending in to CMS. And so when you talk about the pre-populated 248 beneficiaries, That's talking about the web interface, and the web interface is not an option for individual reporting.
Okay.
Does that help?
Yeah, so that does not
Oh,
apply
okay,
to us.
great. Okay.
And that's what we were trying to clarify, if that applied to us.
Sure.
And so in this instance, when we are putting a code on a claim to Medicare, they're only looking to say that 50% or greater have coding for the PQRS for them. Is that correct?
Your claims would have the G codes on them, and they would go to your MAC first, and then they would be reviewed at that level. And then you would get, in your remittance advice, you would get a code returned from your MAC that would indicate that they did receive the PQRS code for that quality measure, and so that you have some way to kind of track that as you go forward.
Is that the return code that they provide to us? Is that something that comes back to us throughout the year, or is that something that comes to us after we, at the end of the year, after they've reviewed everything for a whole year's worth of data?
Well, it should come back with any remittance advice to you. So once the claim is successfully processed by your MAC to CMS, then you should be getting a remittance advice document back at that time for that batch of claims that you sent in together.
Okay. So when it says report greater than or equal to 50% of applicable Medicare Part B fee-for-service patients, then that appears to me that if there are some claims that go out that do not have a code on them, that they're looking for at least 50% or greater to have one on them.
That's right. Of all of the Medicare Part B patients who are qualified for that quality measure, and that were seen by that same individual EP, they're going to be reviewing those claims to make sure that you reported on those that you could report on so that your denominator would be correct.
Okay. So I have one more question in regards to that. So, there's discussion about the measures. Some of them say that they just need to be reported on once per measurement period. Some say a minimum of once per period. And of course, some, as we know, say every time, and then we'll just take the best, the most recent quality data. Because we report on claims, we could have a measure where it says report a minimum of once per reporting period. And so we could report the data that the quality action was performed, and then the patient may come in 2 more times, and now we haven't performed that action because it didn't need to be performed on those 2 services. But, our organization is trying to get a PQRS code on these visits so that we can show that, we did perform the quality action. So I guess my question is, if we were to do that and give it a performance not met, so we had a performance met in January, the patient came in 2 more times, and we didn't address that quality code, and so then we give a performance met 2 times after that, is CMS going to take that most recent code that says performance not met?
Well, okay, so this is kind of complicated. So you're right. Some of those measures have different time frames in the denominator. So I guess the thing that I would recommend that you do is that you look for quality measures where you are most likely to meet the denominator inclusion of patients. So if, for example, you might have some, I'm trying to think of maybe a follow-up, maybe the patient comes in for something acute, and then there is a follow-up visit done, but perhaps there is no follow-up visit done. So if the follow-up visit is something that is normally done at your clinic and that's part of your workflow, then perhaps you want to look at a different quality measure so that you can meet those time frames. There's lots of measures, and the denominators differ from one.
I think the issue for us is because we have a separate billing system than what we use for our electronic health record for structured data for our patient when we see it for clinical data. And so we don't have a way to track if we have put a code on a claim that goes out the door to Medicare. We don't have a way to track have we already reported that code. So what we try to do is just put a code on that claim every single time the patient comes in, for a certain quality measure, so that we can make sure that we are addressing it. And so that's, I guess, what we're struggling with, because if we have a patient who comes in January, February, and March, and we perform the quality action in January, when the patient came in February and March and that claim went out the door to Medicare, we would like to be able to put that quality action code on the 2 subsequent claims to say that, yes, for this, performance time, this measurement time, we did perform the quality action. And if they're looking, if the patient came in 6 times and we have 6 codes submitted, what we're thinking is that they're going to take the most recent value. So that one is going to say either performance met or performance not met, even though it was met.
I think maybe why don't we take this discussion offline, because I think there's a number of other issues that play into this question.
Okay.
Can we do that?
Yeah,
that'd be great. And we could have a conference call on this so that we can clarify it from all angles. I think that would be a good idea. Okay. Sounds good.
Who is talking, please, so that we can make sure we're following up with you?
My name is Kathy Hetrick.
And what state are you from?
Wisconsin.
Okay, thank you so much. We'll follow up.
Okay.
Okay, and I do have one more question in the queue. One moment, please. This question comes from Elena Beeson. Your line is open.
It's actually Mark who's submitting the question here. But my question is, if I'm a critical access hospital, I'm doing method 2 billing, it's unclear to me whether or not we qualify for PQRS. How do I make that determination and determine which providers might be impacted by PQRS?
Okay, this is Gwen, and thanks for your question. Your critical access hospital who is doing method 2 billing, on the claim form now is a spot where the rendering provider's NPI number can be added. And once that rendering provider's NPI number is added to that claim form and sent into Medicare, that's how they identify which EPs billing through the critical access hospital are billing Medicare Part D fee-for-service through the critical access hospital. So take a look at the claim form that you're using. And the new process that started in 2014 to allow EPs to bill through their critical access hospital and also report for PQRS is based on that rendering provider NPI number that is on the billing form. Does that help you?
We're talking it through right now, thinking it through. So if I'm hearing that right, if we include the provider on the claim form, then that provider is eligible for PQRS.
That's right.
So this is Candy, and I want to be mindful of the time here. It's 1 o'clock, and so if we haven't answered your questions, also just a reminder that the kinds of questions that you're asking are the kinds of technical assistance that we can provide to you over the next several years. So please feel free to contact one of us in your state so that we can provide you with any additional information you are looking for. Laura?
Thank you, Candy, and thank you again for joining us today for the PQRS What You Need to Know in 2015. As a reminder, the slides are available on the LSQIN YouTube page. They'll pull up the evaluation questions. Please take a moment to let us know how we did today by filling out the evaluation. Thank you.
Thank you, everyone. This does conclude today's teleconference. We thank you for your participation. You may disconnect your phone lines at this time.